to Dr. Suzanne Dawson, who's our lead admissions tutor here at Leicester Medical School, who will hopefully talk you through lots of useful information that you need to know about medicine. So without further ado, I'll hand over to you, Suzanne.
Thank you, Sarah. So welcome everybody. This session really is, I'm up here for you to ask questions really. I mean, I've got some slides as sort of how we might format the session, but it's basically to take questions from yourselves. Just to set the scene, I am an admissions tutor, but I'm also a practicing consultant within the NHS. So I have 2 full-time jobs that I try to do in a half a week. We all know about that sort of thing. I come at admissions perhaps with a slightly different thought process than some people, in that yes, I work for a university and yes, I have to follow the university, but actually I want bums on seats in 5 years' time that are going to work in the NHS, and ideally are going to stay working in the NHS, and they're going to look after me, my family, friends and yourselves in the future. And that is what I really think we need to be trying to advise these people about, is this is not just a 5-year degree course. You know, this is the long term, and I accept that at the moment there are lots of other things going on. You know, they've just announced that junior doctors will continue striking for the next 6 months. I do not blame them. I graduated with no debt. They are graduating with about 100 grand in debt. If they stick the course, we have a good wage. You know, we are in the top 10% of the population, but compared to people in a lot of professional jobs, we are not paid well. So when they are still given that debt and they are in the working conditions that they are, I'm not surprised they're unhappy, particularly for the first few years. And we are losing them to countries with better work-life balance, and we need to change that. And the government is the only people that can do that. Well, actually, they're not the only people that could do that, because we need to fund the NHS that we want, but that's another story. Anyway, what I sort of have as sort of points of discussion, and really I'd say I do want this to be points of discussion, is about, you know, is medicine the right career for them? What advice can you give them? Where they can get advice? What do medical schools look for? And obviously I can only really say what does Leicester look for, but I think there's a lot of similarities between most of us. And then I thought we could talk through the admissions process, if that was helpful. So in terms of the right career,
I'm so sorry to interrupt. Thank you so much. Sorry.
So in terms of medicine is the right career, we really bring you back to what I was saying at the beginning. This is not just a 5-year degree course, this is a profession. I think it is a vocation. I'm not sure that everybody who's coming into it thinks of it that way. Work experience is difficult to get though, so we can't insist on work experience. But I think there are ways that they can try and think about, you know, what the realities of this is like. You know, have they been to the doctors ever? Have they been in a hospital ever to visit anybody? You know, they can't know nobody who's not had any exposure to healthcare. Or I struggle to believe that anybody can know anybody who's not had exposure to healthcare. So asking those people, what is it like? What was it like to be a patient? What did they want out of staff? What were they expecting? Thinking, you know, that if they were ill, again, what would they want? You know, they want people who are there whatever time of day or night they're ill. This is not a 9-to-5 job. It's not a Monday to Friday job. We are increasingly in a world where people want an answer now. And actually, in a lot of medicine, you want to let time take a bit of, you know, time's actually a great diagnostic tool, but they have to try and deal with people who want responses now. We all want things now. And so it's starting to think about what it's going to be like. Lots of jobs, though, give you interaction with people and dealing with tricky customers. And actually, you know, turning up and doing a shift regularly at McDonald's is usually my example. They are such good transferable skills, really good transferable skills, and we shouldn't knock that. Care home placements, lots of people do it. I'm not sure it really tells you about healthcare but it gets you used to the fact that, you know, the majority of the population you will be looking after is elderly, is frail, and we can't cure those. They will die. And that is something that a lot of people come into medicine thinking they're going to save everybody. Unfortunately, you're not going to. I'm a geriatrician. I certainly don't save everybody, but I still have a very fulfilling job, because actually making somebody's quality of life as best as you can is really fulfilling, and giving them a good, dignified death is fulfilling. So, but I think the biggest, as an admissions tutor and somebody who deals with the medical students and the issues that they have, I think the biggest difficulty we have at the moment is a cohort of people who need adjustments and think those adjustments are going to be made in the healthcare profession. And there are adjustments that may be made when they are a student that cannot be made when they work on a day-to-day basis. So we have students regularly asking for quiet rooms for examinations, for extra time for examinations. I'm not saying that I'm against any of this. I am just saying they need to think about the reality. So last week I turned up to do my clinic and the builders are in the corridor. There is no other room for me to go in. So I have to do my clinic with a frail elderly population coming, with them hammering, drilling, shouting at each other, cables all across, ladders. That is the reality. And you know, if people can't cope with that noise,
Yeah,
if they can't cope
12:30, yeah. So I'll see you in 15 minutes.
Yes, thank you so much.
if they
Okay.
can't cope with the rapidity of change and uncertainty, they are really going to struggle in healthcare. And for me, the extenuating circumstances bit that you now have access to in that UCAS reference is invaluable, because a number of students do not declare issues because they think it's going to cause problems. In 10 years, our occupational health department have said 2 people are not fit to start. One, because they were so sight impaired, they could not safely read vials. Would you want to be having the wrong drug drawn up? Do you think that is a reasonable adjustment as a safe healthcare professional? We had a lot of issues with the student about that. They thought it was unreasonable not to be taken on. You wouldn't want a fighter pilot or a pilot even. You know, there are certain things in medicine we have to be able to do. The second student had very, very significant psychological issues, very significant. But otherwise, you know, we have lots of students with neurodiversity, other issues, but some of them do struggle when they qualify because they have not thought what it's actually going to be like on the shop floor. So they're things that you might try to talk to some of your students about. In terms of occupational health, the main reason we use it is support. So category we're seeing quite a bit recently is people who've had eating disorders but think they're better, and great that they've made a recovery and are functioning really well, but there is a high chance of them relapsing when they start medical school. Not all of them, but there is evidence of an increased chance of relapse. If we get them into occupational health before they start and signpost them and offer them support, they don't go down the same bad route. If they do not have that background, that support, and don't tell us anything and we don't know about it, and then they start, it's much harder to pull them back. So them telling us stuff, or yourselves putting things in the extenuating circumstances, is really beneficial to them. They may not see it, but it is.
If someone actually does successfully get onto healthcare and starts a 5-year program and nothing's been declared from the sixth form institution, but then what support is put in place during their 5 years if something becomes apparent.
Okay, so I mean, they all have to complete a screening form anyway. So if they haven't declared anything, something may be declared there. But yes, some people will come with absolutely no problem at all. The problems become apparent on the course.
Yeah.
So every university is different, but we have our very own pastoral support unit and academic support unit, which is headed up by a GP with a lot of occupational health experience and GP experience. And they all have personal tutors as well. So there are mechanisms to pick them up and support them if they develop issues on the course. But if they've already got issues, I'd say it's much better that they know about that and have thought about things before they even start. So in terms of sources of advice, the Medical Schools Council has a really good website about applying for medicine. It allows them to choose a sort of course, put in their qualifications. It will start to then tell them which universities might be better fit for them. That then may focus them in terms of then looking at university websites or attending open days and things. So there is some gaming from students about where do I think I'm most likely to get in, and you know, in some respects that's sensible, but actually most of the playing field is fairly level, and what they really should be thinking about is what style of teaching do they like, where is the university, how far away from mum and dad is it, do they want to be near, do they want to be as far away as they can get, you know, do they want to take up sailing, so they need to be on the coast, are they not that bothered, do they want to be in a big city on a campus with other students, or do they want to be in a medical school? So most of the London medical schools are medical schools, or they might be healthcare, but they're not widespread university courses. You know, Hull York, lovely campus, but it's out of the city. So these are the sorts of things that they need to be thinking about, because they're going to be there for 5 years at least. They do a foundation course, they're going to be there for 6 years at least. If they need to resit, time goes on. If they intercalate, time goes on. And also historically, people have often then stayed where they graduate. That's changed. That has changed over the last few years. And the foundation programme and how it selects allocations is changing. So you know, that probably will change more in the future. But they need to think about where they're going to be happy for 5 years, because it's a long time. Well, it's a long time to them because it's a significant proportion of their life. It's not such a long time to those of us approaching retirement. So, you know, that to me is what they should be thinking about, is where are they going to be happy? And that's where open days, offer holder days, if they get to that stage, talking to students who are on the course, that's really what they need to be thinking about. But so the medical school website, the Medical School Council website, gives them a lot of information. The biggest issue we find is people not knowing that they need to do aptitude tests. So most medical schools now ask for UCAT. BMAT is no longer, so a lot of the BMAT institutes have changed. So UCAT's got deadlines, so applications usually start in May. They register in May, rather. They can start sitting it become the beginning of June, July, and then the last sit is usually the end of September. And obviously UCAT's closing date 15th of October, so they need to get on and do that. That website has lots of practice tests. They do not need to pay to go on a course. There is no evidence that going on courses makes any better school. They need to just sit down and do the practice tests and do it under test conditions. It is time dependent, you know, each section is on a different time. So in terms of what medical schools are looking for, I was talking to somebody earlier about, you know, how, you know, your bright students, actually your brightest students don't want to do medicine because they're going to get bored. Your brightest students need to be going off and devising some new fantastic great bit of engineering or product or something. They need to be medicine ain't like that. Most of medicine is routine. It's busy, and you need to know a lot of facts, and that's why we ask for the grades, because we have such little way in our education system of assessing people's ability academically. And what you need is to be able to absorb lots of information. You do not need to know lots of highfalutin, problem solving, this, that and the other, but you need to be able to absorb lots of information. And so people who are real geniuses will be bored. And so I think, you know, there is a tendency for schools sometimes to go, oh, you're really bright, you should do medicine because it's got high grades. Medicine is much, much more than that. You really should be doing medicine because you want the challenge, you want the you don't averse to the responsibility, you like the diagnostic intrigue. Yes, you also need to like people, you need to want to work with people, but any healthcare profession has got those caring aspects. So the things that make me different is I make the complicated diagnoses. I decide on the treatment plan. I then have to pick up the problems when that treatment doesn't work and make another treatment. I need to think about, well, this person's got X, Y, and Z. What's the most important thing to them? Well, it's Z. So actually, should we stop thinking about that treatment for that because that's going to make that worse? They are the sorts of things that we do that other healthcare professions don't do. But the caring side of it is across the board. And obviously, some people will do surgery. I don't do surgery at all. I use tablets, or actually spend a lot of my time stopping tablets because they often make older people worse. But they are the sorts of things that people need to be thinking about in terms of why they want to do medicine, not other healthcare. So in terms of what we're looking for, yeah, we have to have that academic criteria because we've got no other way of assessing things. We need the UCAT, so that's an aptitude test, and everybody will use that bit differently. So currently we weight GCSEs and UCAT 50-50. Other medical schools have a UCAT cutoff. Other people don't score the GCSEs, they just say, right, have you got this number of GCSEs at a certain grade, yes or no? So again, that's where they need to look at the individual medical school website.
What's the latest advice you can give on the UCAT scoring?
So everywhere's different. Everywhere's different. So it's different every year because it depends who applies.
Okay.
So this year we had less people apply. They didn't take into fact that despite that we said at open day the score will change because we have changed how we are scoring GCSEs. They don't listen. They look at statistics from last year and go, oh, well, I haven't got that score now, so I won't apply. Well, no, you haven't got that score because we've split 9 and 8 into a different thing. You're not all getting the same score. So because we had less applications, it's a much lower UCAT this year. But that will change because next year they'll all go, oh, I can get to interview with that year. And then everybody will apply, and of course the score's going to go up. So it changes very much for us because of how we use it. But there are other schools that just go, hit this score, you're in. So they need to know what each school's doing.
Sorry to go on a bit of a tangent. I just wanted to ask, you know how Leicester University is obviously acknowledged the fact that you have so many high achieving students and they've now obviously introduced foundation course.
Yeah.
And it's great.
Yeah.
I was wondering, as a practitioner, what conversations are happening with government from educational institutions, kind of like make a more open playing field, because
so the medical school councillors have this selecting for excellence policy for year, and that's why there are the foundation programme courses, why there are different we have this there's a group of us, about 7 of us are in it, called UKWP Med, that takes students who have got specific progression courses, one of them being the Access Leicester Medicine. But there's not every university is taking those courses. So there's lots done, but it is a delicate balance between taking students who then don't progress. And that is one thing that we've particularly found through COVID, that people who are coming on with 3Bs, with COVID 3Bs, have really struggled. And that's not good for them. So there's a lot been done. There's a huge amount of work. And the intake we have now, well, most places, does not look like it did when I was a medical student.
So about the A levels, so we get quite a lot of kids in our school want to do medicine, and they'll all do chemistry, biology, maths.
Yeah.
And we try and, I've been said here by people, do they have to do chem, bio, maths? Can they do chem, bio, and then do something else for that third one?
Yeah. So again, they need to look at different institutions. So Newcastle don't even ask you to take any science. I personally don't quite know how those students then manage. As somebody whose best friend hadn't done biology A level, and boy did she struggle. I've got a current first year who hadn't done biology A level, and she's struggling a bit. So we asked for chemistry or biology, and then one of chemistry, biology, psychology, maths or physics. And then the third one, we don't care what it is. The only thing we would say is if it's a language other than English language, we would ask you to say whether you're a native speaker or not, because if you are, we would give you a higher offer, because we would expect, obviously, you know, it's done as a second language, isn't it, the A level? But no, we get lots who've got history, English, French, geography, economics, absolutely, and we certainly find that those who've done an EPQ as well often have developed other skills that are really helpful when they come. So we certainly don't want just chemistry, biology, maths, but not all institutions are like that. Sorry, I've got the lady here at the front, and then I'll come to you. Yeah, so
with regards to, obviously, we see our students apply, we've seen them for years prepping all this stuff, going out and getting work experience, etc. And we know them as individuals. And sometimes it feels quite frustrating that the student who scored highly on the UCAT, who perhaps doesn't have the personal skills, the empathy, the resilience, but gets called for an interview because they've got the score, whereas the student who scored slightly lower but has spent years trying to get into medicine and absolutely has those skills is kind of overlooked. Do you have some advice as to what the best pathway is for that student, as to what they should do in order to then enter medicine?
So my first thing would be have a gap year. So gap years for me mean I give an unconditional offer when I give an offer. If they accept that, that's a bum on a seat. I'm not sweating about, are they going to convert, blah, 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 blah. So much better for me. For them, that's a second year of practice for UCAT, a second year to develop a bit further as an individual, perhaps mature a bit, get a bit more eloquent, perhaps even start a job as a healthcare assistant or something in that time from finishing school to coming for interview, which will give them masses of experience to talk about at interview and confidence. And so Leicester, we have a different, you know, if you every year we change it slightly, but essentially if they've met our minimum GCSEs, have got the A levels within 2 years, and have a UCAT that is within a range, we so for the main course we don't say a cut off, but for this particular bit we do, we'll take them direct interview. So, you know, they don't have to have such good GCSE grades, they might have a slightly lower UCAT, but they've got their A levels and they've got everything first sit within 2 years. So the important caveat there is the first sit bit.
So you would accept a second application once the gap year is done and they've got their A levels?
So the other thing I would say is we interview far more than we have places. So we would like to think that not everybody, but that we are trying to broaden who comes to interview. And then the offers are made on the basis of their interview. But obviously that's not going to cover everybody. But we would certainly say that we're not just taking people with really high UCAT scores here.
Is there any benefit in taking 4 A levels?
No, we give them a different offer. So rather than A-star AA, they get an AAAB offer. But to us, no. again, I always wonder, why would you take 4 A-levels when you only need to do 3 for most courses? I've never quite understood it myself, but that's perhaps because I, don't believe in putting extra stress on yourself if you don't need to.
What about BTEC science?
So BTECs are really, so this is tricky, and this is because, again, it's about that progression. So for the 5-year courses, I'm not aware of a 5-year course that will take BTECs. Our 6-year course will take the BTEC and the extended BTEC in applied science. That's the only one we'll take. But we have found that those students do tend to struggle. But we are accepting it. We're not going to take T-levels. I think there may be 1 or 2 places that have said they will consider T-levels, but most medical schools have said no, because of they felt not to have that academic, significant enough. The balance of academic to other things, academic to other things is not so. Yeah.
Are you involved with the medical doctor degree apprenticeship?
No, so we're not getting involved. The stance we take is we cannot see how we can possibly teach them as much theory as we teach our current students while they're currently working. We just don't see how it can work. My personal opinion is that I just don't see how it can work. I just don't see how it's going to, I think you're going to end up with 2 tiers of people, and I don't think personally they should be both called doctors. I think you've got to look at physician associates and what's happening with those at the moment. But I don't think enough of us, we don't really know at the moment what it's going to look like.
But as a university, you're not getting involved with it.
No,
that's great.
No, the trust is keen for us to, they want to. But as a university, we cannot see how we can teach to have this, because the learning outcomes should be the same. They're going to have to pass the medical licensing exam that everybody has to take now. And so they're going to have to know the same amount, but how do you teach that alongside them working? That's the bit we just can't see how it works.
Okay, thank you for
answering. So in terms of the sort of admissions process then, so I mean, so what makes the good, so patients like, so this is a real difficult, because ask a patient, what do they want for a doctor? They want somebody they like. They want somebody that they warm to, somebody that's empathetic, somebody that understands them as a human being. Those things are really, really important. But also we do need people who can do brain surgery or heart surgery, or, and that there's perhaps a little bit of, those people might not perhaps have all the soft, fluffy things in the same proportion. So we look for the compassionate side of it, but actually we can also teach some of that. We can also teach some of the communication skills. So, they again really need to be thinking about what I was saying earlier about the fact that, there is competition in jobs. So, we are short, but there's competition. If they want to work in London, that's going to be difficult. If they want to work in North Wales or Northern Ireland, they'll bite their hands off. There is a move away from super specialisation because we have a frail elderly population that have lots of issues going on, and therefore we need generalists, not specialists. There's also been so much innovation in medicine that now a lot of things that used to be done by surgery are now done by interventional radiology. So, jobs are changing. As I said before, it's a 7-day job. You don't need to, you just don't have to open a paper or look at the BBC News to hear about the challenges within the NHS at the moment. And, they are going to have to deal with that. They're going to have to deal with people moaning about waiting, not getting test results in a timely fashion, delays in their surgery, etc. And it's lifelong. So one of the examples I would say to the medical students is when I was a medical student, we were told you never give a beta blocker. We'd never give a beta blocker to anybody with heart failure. Now if you don't give somebody with heart failure a beta blocker, you would be considered negligent. Medicine is changing all the time, and they need to be up for that lifelong learning. And they also need to be up for revalidation. So I have just gone through my revalidation for the 5 years, which means for another 5 years I'm okay. I'm not planning on renewing it after that. I'm calling today. But the revalidation process, I have to show that I have been stayed up to date, that I have gone to appropriate courses. I have to reflect on every single complaint that I have. I have to declare every if I've been to the coroner's court, or in which Dr. Warden haven't been for quite a long time. That's actually another thing to tell them. They will end up in the coroner's court. Everybody who's a doctor will end up in the coroner's court at some stage. Not a nice experience. I have to show feedback from patients, I have to show feedback from my colleagues, and I have to have an annual appraisal. And every single doctor has to do that to say revalidated with the GMC. So again, they've got to be up for all of that. I've covered a lot of this as we talked about work experience and support. So Medical School Council, again, got lots of information on their website about work experience. There are various places that do things like Observe GP, Brighton and Sussex Medical School do. We have a thing in Leicester that my colleague Dr. Goodfellow does with some online work experience. You can also go onto the volunteering.co, I think it is, or is it volunteering.org? Anyway, there's about finding out volunteering opportunities. We had quite a lot of done food banks or soup kitchens for the homeless. You know, that again, the homeless society is really underrepresented in terms of getting access to healthcare. So, you know, talking to them, what do they need? You know, that again, that's a huge learning experience for students. In fact, I've got it on the slide, I forgot about that. So yeah, so there's about the healthcare careers, studying healthcare. These are all other websites that are up and coming at the moment. And there are links to these from the Medical School Council website. So in terms of what happens, they need to check, do they meet the entry requirements? Have they got the right aptitude test? Every medical school uses the personal statements a bit differently. We only use them at the point of offer, and we use that again to see is there anything they have mentioned that makes us think we need to get occupational health involved. That's why we use them. Otherwise, we don't, and that's largely because there's increasing. Well, obviously now I was going to be concerned about have they been written by ChatGPT, etc. But you know, there's only so many times you can read. So they all say, "I've read Being Mortal" by Atul Gawande. Brilliant book. Not knocking it. It's actually a really good book. But they don't say, "I've read Being Mortal. It has made me realise that actually we've got people who are living with lots of healthcare conditions, that they've got poor life expectancy, and actually by stopping their medication we may make their quality of life better if we don't make their quantity of life better." They don't write things like that. I'm not expecting them necessarily to reflect like that at 17, but it doesn't tell me anything. I've read Being Mortal. So that's why we personally don't use the personal statements, but we have a station in our interviews that is looking more at them, so it would be an opportunity to discuss it then. Some medical schools do have the personnel to read all 3,000 applicants' personal statements. So again, they need to see what that institution is saying about that personal statements.
Do you actually say on the website that you don't?
Yeah. Oh. And work experience we've talked about. So interviews, most places now run multiple mini interviews. I think post-COVID, there's probably about half are doing them face-to-face, half are still online. Those that are doing online, are often doing a mixture of what's asynchronous, so they send them something where they record it and upload it, and then they do some live online ones as well. We've gone back to face-to-face because, well, for a number of reasons really. Our interviewers prefer it, the candidates on their feedback prefer it. One bit that the university has not got its head around, and I'm about to go into battle about this, is that they've set me targets for the offer holder days, which I think are unrealistic, because actually I don't think people are going to come to offer holder days because they've already been to an interview here. And as part of that interview, we've given them a campus tour, we've got them to talk to a medical student. What you know, there are things that we're going to do at the offer holder days that's different, but money is a big issue for everybody. Money, we have strongly thought about whether we stick to online interviews, but we actually think the interview process starts from the moment they enter the building and it finishes at the moment they leave the campus. And we have found, again, it's small numbers, but students who, you know, might be very good when they're in the interview, but when they're in a group with other kids or out talking to the ambassador, have got some really not very professional behaviours. And that's why we actually want to look at them face to face. So we are not planning to change back to online unless we really have to. Offers for us are based on their interview. Again, some places will use a bit of the UCAT, will use their A levels, will combine it all together. Again, they need to look, what does each place do? We just look at the interview score, but the offer making process, and however much we try and tell them this, the student room, so I have 290 places, 18 foundation, 18 overseas rather, 35 foundation. That 35 foundation count in the 290 for that 5-year course. So effectively, I'm down to 240 something. So I'll make, say, 500 offers. But if everybody's waiting until the UCAS deadline, which is the 8th of June, to make their decision, and I'm sitting there with all these people who've got conditional offers and I don't know what they're going to do, I can't make more offers till they've made their decision. So the sooner they make a decision, having got their offers, the sooner I can make more decisions. So, you know, when people start going, so, well, you know, if you make your decision from the offers that you've been given, I can make more decisions for the people who haven't got offers elsewhere. So it is a very long process. And I'm afraid because it's a capped course, it's always going to be like that. We can't go over. If we go over, we are fined. If we go under, we go into clearing. The university hates it. So immediately turns around what I say. I don't want to go into clearing. It's an awful lot of work, but actually we pick up some really good candidates through clearing. But I can't go over. And that's the bit that is really difficult for students to get their head around. If they don't make their decision, and then if it's a conditional offer, they've got to meet their grades. So there are all these factors that determine the offer making process. In terms of multiple mini interviews, we tend to keep our interviews fairly to ourselves. Essentially, we run 7 different stations. One of them's in the university station. The others, there might be a clinician, there might be somebody from professional services, there might be an actor, and we're looking at different aptitudes in that. One station will be based around their personal statement. You know, there might be a video to watch, there might be an article to read, those sorts of things. Sheffield were giving out their questions ahead of time. As I understand it, they're not doing that this year. Say some of them are doing, you know, recorded things beforehand. Everywhere's different. In terms of interview prep, we very much our interviews are done. We don't want rehearsed answers. So some of them will pay to go on a course and they'll get taught about the pillars of ethics. Well, we're going to teach them that on the medical course. Or somebody would have told them about capacity assessment. Well, we're going to teach them that on the medical course. We don't actually want them to know about things like that. We want to get a feeling of who they are, what drives them, what their passions are, what their values are. Are they going to fit in with Leicester and our values and our other students? And so we don't want rehearsed answers. And some of them will try to work in. So I'm just trying to think of an example, but we might say something like, what did it makes a good doctor? And they'll suddenly work in about, oh, well, if you're looking after somebody who's a Jehovah's Witness, then they can't have a blood transfusion and this, that, that's not what I asked you. You've been on a course that's told you that. You think you've got to work it in. They will mark down because they've not answered the question. So it's really, in terms of preparation, it's, can they sit one-to-one with somebody? If you ask them a question, have they got the techniques to, pause a bit, think about it without being awkward? Perhaps ask them to repeat the question if that helps them better, if they don't like silence. Then to come together with an answer that they can put together in a timely fashion. So we tell them how long they've got, we tell them how many questions they've got, they should be managing their time. Now our interviewers will move them on a bit, but those are the sorts of things for them to practice. If you chuck some random question at them, can they come back with an answer? We probably need to have an awareness about, current topics in the NHS. If there's some major, so like at the moment, they might get asked what they think about the strikes. If there was some mega, like if we'd had the first heart transplant, we might expect them to know about, what do they think of that? Is that a good? But they're not expected to be reading medical journals and know things that they're going to come on the course to be taught. But again, different places do different things. I think that Oxbridge still do tend to expect them to know a bit, perhaps give them a model of a heart and ask them about that. I mean, we wouldn't do that. That's what their A levels are doing, is to look at their academic ability. It's the interviews to look at the other things. And that's really, they're all the slides I'd got. I'm very happy to take questions. So last year was really, questions were just being bombarded at.
Now you mentioned that you had picked up some strong candidates for clearing. With the sample that you just showed us of the process that students go through with you, what does that look like in that really short window of time now on the clearing day?
So we would hope not to be in clearing, but I mean, there are places. So George's, for instance, do go into clearing specifically. So last year we did have to go into clearing. So they rang up on the Thursday. We interviewed them on the Friday. Right. We made them offers on the Saturday. Okay. For the foundation year course, because we have to check some of the data and eligibility, they were interviewed on the Monday, and they got the offers on the Tuesday. But essentially, because we're competing with other places that are going into clearing, they can only have one offer. It's not that you can have your insurance or conditional, etc. But that's how it looks.
In that scenario, would they already have to have taken their UCAT, or do you?
Yeah.
So they'd already have to have.
Yeah. So they'd have to have a UCAT in hand. So they would have been people who were planning, who had applied but not been successful. Yes. Those people who, and I'm not against this at all. If you've got somebody who's just not sure they're going to meet the grades and doesn't want to put themselves under that pressure of applying, don't apply. Get your grades, concentrate on that, and then apply in a gap year and do your UCAT practice after you've done your A levels and you're waiting for your results.
From your side, from last year, what was the volume of applications you had here for medicine?
So we usually get 3,000 applications.
3,000.
Based on the percentage chances of students actually getting in, this is not a Leicester question really, but it's just what's the rationale behind UCAS or the students being told they can only apply 4 out of 5 choices for medicine?
No idea. I don't know why that decision was made.
It just seems, if they are genuinely want this, then it seems a shame that they lose at least one choice.
Oh dear, right.
I think it's to do with the fact because medicine is so competitive, the fifth choice allows them to still have an offer in place. So often they're encouraged to take a course that maybe, for example, like clinical science, medical sciences, that maybe it's an option of transfer, or it's something that maybe them is further they want to do graduate entry medicine. But the idea is it gives them safety net to in theory not be placed into clearing or UCAS extra, which I can appreciate. It has evidence that lots of them don't really want that fifth choice, often it's not, but that was a logic around why it was introduced, because it felt it would be undue stress, pressure and stress on students to find themselves with no offers. And that's like the approach generally they get that fifth.
Just the odds are already stacked against them, and then we lose one extra. I get totally what they're saying, but I just think sometimes, like you were saying,
So that's what's about the gap year. So I really have no idea whether people have taken a fifth choice or not until after the A-level decision day, the UCAS decision day, not A-level decision day. And at that point, we would usually have a waiting list, and we will have been communicating with them. And if they've got other offers in medicine, they have to make a decision. They cannot be on our waiting list. If they have a fifth choice, they can be on our waiting list. But if we make them an offer in UCAS extra or clearing, they have to give up that insurance, that they can't have an insurance. Essentially, they've lost the ability to have that because you can only hold one offer in extra. But I would say, and again, it's the difficulty is you've got these, they're young, aren't they? And a year is a hell of a long time for them. Whereas a year's like, oh my God, it's another year's gone already. I would say take a gap year. So apply for, I hear what you're saying, but just apply again. Some places will consider you if you're a first year student of another degree. So we do. But there is a part of me that thinks, that's you're sort of detracting from the university experience, aren't you? If actually you've started a course, but you're applying and all you're bothered about is have you got an interview and in practice and blah, blah, blah. Just have a gap year. But I think some families perhaps don't feel like that. And I am going to say this because it's what I understand is I think also some schools, because you get somebody placed, and from a statistics of so many of our years gone to university, might make things look better, but it's probably not the best for the student. So there are courses that do internal transfer. We do take some through it, but it's very competitive. We've had a little run of a real issue where we have this clinical science course that actually sits alongside medicine, and we've got students who didn't meet their grades who start that and then think, well, they'll just transfer, so they've not lost any time. And we keep saying to them, this is really competitive. There is absolutely no guarantee that just because you had an offer before that you're going to get to that stage. But, so gap year would be my advice. Yeah. Oh, sorry. Yes, I'm good. I've just got one question. Yeah.
So have you? Sorry to ask such a direct question. Have you already sent out all your first range of offers for this year? No. Okay.
Yeah.
What has been the general trend in terms of quality of applications that you've been seeing?
I would say on paper, they look the same. I would say that we have had a significant issue, particularly with our 2021 intake, because they probably were not as academically strong as they looked on paper. But I think that's more complicated than that, because I think the whole, online learning, switching to, it's so complicated. But we have had a very challenging time where we've had more people leave than normally would. the lack of academic progression. We're seeing that seems to be coming up again. So I think on paper, I wouldn't say there's been a major difference. Because we changed our criteria this year, we've gone to A-star AA. We've noticed a slight, perhaps a bit A-level predictions better, but a range of GCSEs and a new cap. So yeah, on paper, I don't think it's changed that much, to be honest.
Can I say a big thank you, Suzanne, for showing that detail. It is lunch